Hey there everyone, welcome back to Studying with Stephanie. I'm Dr. Stephanie Audish and I'm a doctor of physical therapy. Today we are going to discuss spinal cord injuries and the neuroscience behind some of those injuries. So let's get into it. What is the spinal cord? Well, the spinal cord is a part of the central nervous system, including the brain and the spinal cord itself. The spinal cord exits out of your skull at the foramen magnum and goes all the way down to the level of L1 or L2, depending on each person's anatomy, and this is called the conus medullaris. So the spinal cord is composed of white matter and gray matter. Our white matter is going to have our afferent sensory neurons as well as our efferent motor neurons. Gray matter is going to be in the center of the spinal cord and is going to be shaped like an H. So it's easy to detect the difference between the white matter and the gray matter. Like I said, the white matter is going to contain those sensory and motor pathways and essentially be the highway of our spinal and nervous system. The spinal cord as well is supplied by 3 arteries. The anterior spinal artery and then 2 posterior spinal arteries, which give it the blood supply that it needs. And lastly, the spinal cord has 31 spinal segments, which compose of the ventral efferent motor nerve roots and the dorsal afferent sensory nerve roots, also known as VEM-DAS for short. An easy way to remember: ventral efferent motor, dorsal afferent sensory. So anything that's going on in that posterior aspect or that dorsal part of the spinal cord is going to affect more of our sensory abilities, and then anything that is going to be in the ventral part or the anterior part of the spinal cord is going to affect more of our motor, our movement. All right, so that's a quick way to memorize VEM-DAS. Ventral is efferent motor, DAS, dorsal afferent sensory. And again, these are our pathways of how our nerves communicate to our brain from our spinal cord and back down from our brain down to our limbs to give us that detection that we need to produce movement, to maintain movement, or to correct. So let's get into it. So firstly, we are going to look at our ascending pathways, our ascending sensory tracts. Now, again, the dorsal part of the spinal cord is going to give those sensory nerve roots, but the actual sensory pathways are trickled throughout the spinal cord. So if you actually take a look at the photo in the middle of the screen here, you're going to see the dark blue is actually going to be our ascending tracts. And although the dorsal column, medial lemnisci, is at the posterior aspect behind that H, you can see that there are some ascending sensory tracts trickled out throughout the spinal cord. Now, this shows the dorsal and the ascending tracts in the blue and the descending tracts in the red, but all of these are on both sides of the spinal cord. So it's gonna be on both sides, regardless of the blue and the red here depicted. So let's talk about the dorsal medial lemniscal pathway. So this is going to include the fasciculus cuneatus, which is going to be those 2 outer columns within those 4 columns that we see posterior to that gray matter H that we're looking at. So that gray matter H is going to give us that better idea of where to go when we're looking at the spinal cord. And then right behind that H, you see kind of 4 nodules there, and that's that dorsal column medial lemniscus. So including in that fasciculus cuneatus, we're going to get sensory information from our trunk, our neck, and then our upper extremities. So this is where we're going to get a lot of that information from. And then it has the fasciculus gracilis, which is going to be that inner medial part of that column. And this is going to be more of the sensation from our legs and our lower trunk area. Now, the feedback that we get from the dorsal column is going to be more of discriminatory types of sensations. So, vibration, we're going to get proprioception. So, where is our body in space? We're going to get that deep touch, sterognosis, barognosis, graphesthesia, texture, kinesthesia, as well as our 2-point discrimination. And then within the dorsal column, it's going to cross over. So the nerve pathways cross at different points from time to time in order to keep our bodies a little bit on the safer aspect. So those pathways aren't always going straight up and down along the highway. They're going to cross over and merge into a different lane from time to time. And so for the dorsal column, this cross happens to the opposite side in the nuclei gracilis and the cuneatus. So just like it's named after the fasciculus, that is the same areas that they cross over, but within the nuclei itself. And then this pathway terminates at our posterior lateral nucleus of the thalamus. So this pathway goes all the way up from the spinal cord into the thalamus itself. And then we're going to go into another important part of the posterior ascending sensory tracts. We're going to talk about the dorsal spinocerebellar tract. So the spinal cerebellar tract provides proprioception again for the lower extremities and the trunk. So that's where we're going to get some more of that feedback from that dorsal spinocerebellar tract. And then it also gets signals from the Golgi tendon organs and the muscle spindles, which are going to provide our spinal cord with that feedback of our length tension relationships and if a muscle or tendon is being overly stretched or where the joint is in place. And then lastly, this is going to stay on the same side. It's going to stay ipsilateral, and then it goes all the way into the inferior peduncle of the cerebellum. So a little bit of a different entry point into the brain there. And then a few other ascending sensory tracts that we need to go over are the spinothalamic tracts. We have an anterior spinothalamic tract and a lateral spinothalamic tract. The anterior spinothalamic tract provides same-sided light touch and pressure sensation for us. And then the lateral spinothalamic tract provides contralateral, so opposite side, pain and temperature sensory feedback for our bodies. This is going to come into some importance when we talk about some of the spinal cord injuries in the next few slides. And then we have the spinal reticular tract, which again, reticular is like a network. So the spinal reticular tract is actually going to alter our levels of consciousness and have more of an effect on that. And then we have the ventral spinal cerebellar tract, which is subconscious. It provides us proprioception of the upper and lower extremities as well as trunk posture, and it terminates at the cerebellum, but this one does cross over at the pons, so a little bit higher up. And then lastly, we have the spinal tectal tract, which provides us some visual reflexes and helps to move our eyes towards a stimulation, our eyes and our head to move to a stimulus when we are getting that sensory feedback. So we're going to talk about some spinal cord injuries. Now, all of these injuries are going to fall into our incomplete injuries when we talk about the ASIA scale, which we will do so after we talk about these injuries. But since we talked about the ascending tracts and the dorsal column, we're going to talk about the ascending tracts and the posterior spine injuries first. So firstly, we're going to talk about posterior cord syndrome. So if you know your anatomy and your physiology, you know where these things are in the body and what they do. The names guide you to what the impairments are going to be. Posterior cord syndrome is going to affect everything posterior to the gray matter, which is going to be that dorsal column medial lemnisci. So what is that going to affect? If we have posterior cord syndrome, we are going to have a lack of proprioception, a lack of discriminatory touches, sensations from vibration, from 2-point discrimination, from sterognosis, barognosis, all of those things that we talked about the dorsal column does is where we're going to have those impairments. Posterior cord syndrome is more so from compression to that posterior spinal artery, and this is going to be something that is more rare because we know that the spinal cord is supported and protected by our vertebrae, and we have that nice thick spinous process in the back with the laminae to support and to protect that spinal cord itself. So unless that posterior artery gets compressed for some reason, that's when we're going to have this posterior cord syndrome. Now, the next two we're going to talk about are not only posterior or ascending spinal cord injuries. They fall into the category of both, okay? But we are going to touch upon them because it does affect some of our sensory, our afferent sensory nerves. So we're going to go into central cord syndrome. So central cord syndrome is caused by compression to the central spinal cord. This is typically from a cervical hyperextension where that cord gets compressed and now we have damage to the middle of the spinal cord. What is this going to affect? Again, know your anatomy. So a lot of the gray matter is going to be affected with this, and then we're going to go into a little bit of that outer aspects of that gray matter, of that H. So we're going to hit the spinothalamic tract, which is going to be that pain and temperature on the contralateral side, as well as crude touch. We're going to hit the corticospinal tract, which are going to be our voluntary movements, which we'll talk about when we're talking about the descending pathways, the motor pathways. And then we're going to hit our dorsal column again. Proprioception, discriminatory touch, vibration, 2-point discrimination, sterognosis, all of those types of things will be affected when it comes to the central cord syndrome. Due to where the central cord syndrome occurs, it is going to affect the upper extremities more than the lower extremities. Lastly, we are going to have more effect with central cord syndrome onto our motor nerves. So we're going to see more impairments when it comes to movement versus sensation. And then the last one we're going to talk about here that can be affected with a posterior cord injury as well. This is also categorized as an anterior cord injury because of what the injury is affecting. So if you've heard of Brown-Sequard syndrome, this comes from something like a stab wound. You're getting hit on one side of your spinal cord, so that whole lateral aspect of the spinal cord has now been affected. What's going to happen here? Well, this is going to hit everything from our sensory and our motor tracts on one side. Because our nervous pathways can cross over at different areas, this can affect where we're going to get some of those impairments. So let's take a little bit deeper of a look. So with Brown-Sequard syndrome, we have damage to the cortical spinal tract, which is going to be those motor motions. That's all going to be ipsilateral because that pathway starts at our brain. It's a descending pathway. We'll talk about that in a second. We're also going to have damage to the dorsal column medial lemniscus. And again, this is going to be proprioception, 2-point discrimination, graphesthesia, sterognosis, anything that's going to be discriminatory type of touch, kinesthesia, all of those types of things. Then we're also going to have damage to our dorsal spinocerebellar tract, which is going to be more of that proprioception of the lower extremities and the trunk. And lastly, we're going to have damage to the lateral spinothalamic tract, which is going to be contralateral pain and temperature loss. So that is the key when it comes to Brown-Sequard, is that it's going to have opposite side to the injury, pain and temperature loss below the level of the injury. Again, this is rare when it's in its true form, because it's really hard for someone to really just damage one side and not go into the other side of the spinal cord, but it happens. It's a syndrome for a reason. So these are definitely serious injuries that are emergency situations when they happen. They happen from traumas, high velocity impact type of situations where the bones and the body and muscles cannot protect that spinal cord and there's compression or artery flow limitations, and that's when we get these issues. So let's talk about our descending pathways. The descending motor pathways are giving our body the instructions and the cues on when to activate, when to fire. So let's go over them. We're going to start with talking about our anterior corticospinal tract. This is going to control voluntary movements that are going to be more discrete and skilled motion. It's going to affect the same side as where it comes down from. And this is a pyramidal tract, meaning it exits from the cerebral cortex. Then we're going to go into the lateral corticospinal tract. This is going to be, again, voluntary motions, but it's going to be more fine motion that it controls. It is going to affect the contralateral side. So there is going to be a crossover at one point, but again, it is a pyramidal tract, so it's exiting out of that cerebral cortex. Then we go into the vestibular spinal tract. Anytime we think of vestibular, we want to think of balance and awareness of where our body is in space. So vestibular spinal tract is going to control your gross postural adjustments. How do I need to reorient my body? And that's going to be related to your head motion. So if your head is in one way, how do I need to adjust my trunk and the rest of my body? It's going to help facilitate your extensor muscles, so keeping you upright against gravity, and it's going to inhibit your flexor muscles, so that way you don't go into that falling. And again, this is all to help you regulate your posture and your balance when it comes to where your head is in space. And this is an extrapyramidal tract, so it doesn't start within the cerebral cortex itself. It starts a little bit later on, either in the brainstem or the pons, but I'll let you do that studying yourself to figure that one out. Then we have the rubrospinal tract. This is going to control, again, gross postural tone. So not the actual movement and correction of posture, but the tone of our posture. This is going to help facilitate the flexors of our body, and it's going to inhibit the extensors of our body so that they're not in high tone all the time. Again, this is going to be an extrapyramidal, so it's not coming out directly of that cerebral cortex. And then we're going to talk about the tectospinal tract. So the tectospinal tract also helps postural tone, but it's going to be on the contralateral side. It is going to be related to the auditory and the visual stimulation. So it's going to give your body cues on where to move and how to hold your posture correctly based on the auditory and the visual. Again, this is an extrapyramidal structure, so it's not originating out of that cerebellum. And then lastly, we have the reticulospinal tract. Again, reticular is a network. So this is going to inhibit or facilitate our reflexes as well as our voluntary movements. So it's kind of control quite a bit of things. It can help or it can hinder. It's going to influence our gamma and our alpha motor neurons, and it is also extrapyramidal. So let's talk about damage to the spinal cord where it affects the anterior structures or those descending pathways. The main one that we didn't talk about in the other two slides is going to be our anterior cord syndrome. So again, this is going to be due to compression of that anterior artery or the anterior spinal cord itself, typically caused by a flexion injury. Flexing forward causes compression to the anterior spinal cord and therefore can damage that area. So what is this going to affect? Well, we're going to hit the cortical spinal tract, which is going to affect movement below the level of the injury. As well, we're going to hit both our anterior and our lateral spinal thalamic tracts with this injury, which is going to affect pain and temperature sensation on both sides, because we're not just hitting the anterior or the lateral, we are hitting both. So the pain and the temperature sensation is going to be off on both sides. We've already talked about central cord and Brown's cord, so you can go back and listen to that part of this lecture to go over that a little bit more. But again, this is going to affect some of the anterior structures as well, which are going to be those descending pathways. All right, so let's talk about ASIA classifications. So ASIA is a system that has been developed over time to classify and identify the severity of incomplete spinal cord injuries. So let's talk about the different categories. The categories of the ASIA scale goes from most severe to least severe on the scale of A through E. So A is going to be a complete spinal cord injury, everything from sensory and motor below the level of the injury is going to be affected, and this person is not going to have any control of their function of the bowel or bladders at the S4, S5 level. Then we're going to have ASIA level B, which is going to be sensory incomplete, meaning that there is still some ability to have sensation below the level of injury, but there is no motor function below that level of injury. So some of the sensory is intact. This could be done through dermatomal testing, pain testing, vibration testing on both sides to see where those sensory impairments still are presenting or where they still have some function. Then we go into ASIA C. This is going to be motor incomplete. So this patient is going to have their sensation, but they're only going to have motor involvement of some areas below the level of the injury, with a classification of ASIA C. That patient's key muscles below the level of injury are going to be less than a 3 out of 5 when it comes to myotomal screening and strength testing. So they are going to have some ability to move their muscles, which we can have a great impact over when it comes to physical therapy. Then we go into ASIA D. Again, this is motor incomplete. So some of the areas that have motor function below the level of injury are present. And with ASIA D, those key muscles can be a 3 out of 5 or greater. So this patient, again, has a lot more room for recovery because they still have the sensation and the muscle strength greater than a 3 out of 5 in those key muscles under the level of the injury. And then lastly, we have ASIA E. ASIA E is going to have no sensory or motor impairments. They are going to test normal for these different regions of the spinal cord injury. Okay, lastly, we're going to talk about cauda equina syndrome. This is not technically a spinal cord injury because the spinal cord ends at L1 or L2 where that cauda equina starts. The cauda equina is a bundle, a compilation of nerves, again at that L1 or L2 level. That is not a part of the spinal cord but does supply sensation and motor function below our sacral area and to our lower limbs. So with cauda equina, this is actually an emergency situation. This patient is going to have compression to that cauda equina, which is going to alter their bowel and bladder habits. They're not going to be able to have control over their bowel or bladder. They're going to have areflexia, so they're not going to have a reflex when you're testing the reflexes. And lastly, they're going to have flaccidity. So this is very important. We need to get someone to decompress that conus medullaris immediately, that cauda equina immediately, so that this patient doesn't get paralyzed from the waist down, essentially. All right. So that is spinal cord injuries. There is a lot more that goes into spinal cord injuries. As a physical therapy student, if you're taking your neuro course, it is so important to know your spinal cord pathways of your afferent sensory or your efferent motor pathways. Again, this is the highway for your nerves to communicate from your brain down to your body and from your body up to your spinal cord or up to your brain. So it is also important for you to know what part of the brain or the spinal cord they stop or start at and where they cross over to the other side. Because again, when you're coming across an impairment or an injury, knowing where it is, knowing where it crosses, you are going to have that foundational conceptual knowledge of where do I start? What is the actual impairments that I'm going to see with this injury? All right, so I hope that helped. This is the spinal cord injury, and we're diving into more neuro topics. So if you want to see anything specific, please drop it in the comments. I hope that this helped you. Please like and subscribe if it did. Share it with your friends, and I hope to see you on our next video. Thanks for studying with Stephanie. Bye.